and multifocal torics, about 60 out of 150, 160, about say 25, 30%.
Great numbers.
But what I've heard of in general, the statistics in India in private practice would be, this percentage total would be in single digits, is what I've been told. Now I need to be corrected because this is just a hearsay kind of a thing, but I'm fairly reliable on that. So if you're saying in 20%,
can you start
yeah.
now?
Sorry, go ahead, please.
Sure.
Yeah.
We are live now. We are live now.
Okay.
Okay.
Hello.
Yeah.
Yeah.
Great.
Good evening and welcome to Agarwal's round. The topic for discussion today is workup for premium IOL and surgery. We have come a long way from the time Dr. Harold Ridley implanted his first IOL in 1949 and had a refractive surprise of almost 20 diopters. Premium IOLs have evolved over the time due to the need of the patients who expect excellent visual results and perfect vision without spectacles for both distance and proximity. We have with us Dr. Richard Davidson from University of Colorado Eye Center, who will be sharing his immense wealth of knowledge on how to work up a patient for premium IOLs. Dr. Richard Davidson, Professor of Ophthalmology at the University of Colorado School of Medicine and the Medical Director for the Faculty Practice at Sue Anschutz Rogers UC Health Center. He has given instructional courses, conferences, authored numerous chapters in various books. He's been awarded American Academy of Ophthalmology Achievement Award in 2006. So we welcome you to Dr. Agarwal's Grand Rounds. We would also like to invite our panelists, Dr. Ram Nalesa, a senior consultant ophthalmologist at Dr. Agarwal's Eye Hospital, with a treasure trove of experience in cataract surgery. Welcome, sir. We would also like to invite Dr. SRIVASTAVA, who is a consultant cataract and refractive surgery at Raghudeep Eye Hospital in Jaipur and Ahmedabad. He has specialized in the management of complex cataract cases and refractive surgery. Welcome, sir. A warm welcome to one and to all the online users out there. For the online users, if you have any queries or any comments, please do drop it in the chat box below. We would be addressing the same at the end of the session. Now, I would like to invite Dr. Richard Davidson to give his presentation. Over to you, sir.
Thank you very much, and thank you for the kind introduction, and thank you for the invitation to join you. It's a pleasure to be here from Colorado, halfway around the world. I'm going to go ahead and share my screen, and we'll get started. If there's any issues seeing the presentation, just let me know. And as we discussed, the topic is workup for premium IOLs. And we were just discussing before we went live how I'm still amazed that in the United States, only 15 to 20% of surgeons are using premium lenses, even though we've had them in one form or another for more than 20 years. And we can talk about why that may be in a few moments. So these are my financial disclosures, and I have no financial interest in this material being presented today. So as you all know, there are challenges with cataract surgery, especially here in the US. There's a pressure to perform more surgery in less time, but we don't want to sacrifice efficiency and we don't want to compromise safety. We're also seeing that reimbursements are going down, but the demand for better outcomes is going up. Patients are getting more savvy about their cataract surgery, and it really has become a refractive procedure. Now, we never had many choices for years. When I was a resident, which is now almost 20 years ago, surgeons would decide, not patients, which lens. I never had a discussion about what lens I was going to use with a patient. And we made the decision based on various choices, like, type of lens material, cost. Good vision was important, but it was not essential in the sense that, we definitely told patients they're likely going to have to wear glasses afterwards. Let me just see if I can, for some reason my screen just froze on me. So let me just, one sec, I apologize. The screen here just froze, so I'm having trouble advancing.
Restarting it.
Okay, I'm going to stop sharing for a second, and then see if I can get it to unfreeze. I'm not sure why it froze, but let's see. For some reason, I'm gonna have to. Here we go. Okay, it's back. I don't know what happened, but I apologize for that. Nowadays, in 2020, surgeons have more choices than ever. Patients are knowledgeable, and good visual outcomes are essential. You know, a lot of these patients have had refractive surgery already. They've had LASIK or PRK or sometimes RK, and they really have a demand for excellent vision after cataract surgery. Well, it's just frozen again. Let's just see. I'm going to disconnect for 1 second. I really apologize, and just see if I can get this to you.
No problem. Are you using a Keynote or a PowerPoint?
Let's just see if I can get it to share again. It's working fine on my screen, but for some reason when I'm sharing, I'm going to do it this way without going into slideshow mode and just see if that is better here. Just see if I can do that now. Okay, let's just see if that's better. So my point in telling you this is that it's important to try and keep the IOL options as simple as possible for your patients to understand, meaning we only have a limited time with our patients, and it's important to try and be as focused as possible. We have a lot of information to share with them, but we also need to be focused in what we recommend for them. Patients are looking to us for guidance, and if you spread out with 7 or 8 different options, they're never going to be able to make a decision. So it is important to try and focus your choices on what you think is going to be best for the patient. But I do believe we're obligated to offer the latest technology for our patients, meaning, for example, we have some surgeons in our practice that don't want to offer premium lenses. They don't feel comfortable doing that, but we have them offer it. And if the patient chooses it, they will send them to another surgeon in our practice who does premium lenses, because the last thing you want is to have a patient in the waiting room on post-op day 1, and one of them is talking about their multifocal and the other one saying, why wasn't I offered a multifocal? So it's very important that we offer this technology to our patients. And don't assume patients don't want them. We have people in my practice who say, oh, my patients are not sophisticated enough, or they don't have enough money. I don't think it's fair to assume that they don't want them. A lot of patients don't know that they exist, and it's important to make sure that they understand what their options are. There are many, many patients that want to get out of the need or become less dependent on glasses or contacts. And also, don't prejudge any patients. You know, it's very easy to look at a patient and say, oh, they probably don't have enough money to do this. Never, ever do that. You'd be shocked. Some of the least assuming patients actually have plenty of money and can afford it. And so, or sometimes they may not have a lot of money, but they want to put the money together to do it because it's such an improvement in their quality of life. So never prejudge any patient. Every patient gets the same discussion in my practice. I want them to know their options. Premium IOLs offer huge advantages for our patients. These will be some of your happiest patients. You have to choose the patients correctly, but they will certainly be some of your happiest patients, and they're going to advocate for your practice as much or more than any other person who comes into the practice. People say, oh, it's increased chair time. I don't want to deal with that. Well, it is increased chair time, but it doesn't have to be a lot of increased chair time. You can focus your discussion. And remember, you're getting paid for that time. You know, in the US, our reimbursement for cataract surgery has gone down significantly. So this gives us an opportunity to not only do something great for the patient, but also to get paid for our time more so than we would normally. So what premium services do we offer? Well, we offer premium lenses, and that's what we're going to talk about today, but we also offer astigmatism correction using femtosecond laser or diamond blade or with toric lenses. We offer intraoperative aberrometry, and we also use Zepto for what we call premium capsulotomy. But we're going to focus on premium lenses. And just to give you an idea of how we approach this, for laser arcuate incisions to correct astigmatism, we do up to about 0.75 diopters. Toric IOL greater than 0.75 diopters approximately. multifocal lenses for patients who want distance and near vision. And we use aberrometry to assist with some IOL calculations, can be useful in post-LASIK patients. And so, as you know, with intraocular lenses, we have standard monofocal lenses. They can do distance or near, but no astigmatism correction. So in our premium category here, we offer toric, multifocal, or EDOF with or without astigmatism correction, accommodative, and also light adjustable. We have not used the light adjustable lens yet, but that is available in the United States as a monofocal with some correction of astigmatism at the same time. So, you know, as far as the multifocal, you know, we basically use whatever needs to be used in order to give the patient the best possible outcomes. So I don't even have a specific discussion with the patient about whether I'm using a multifocal toric or a regular multifocal. I just tell them we're going to get the vision as sharp as we possibly can. If they ask, then I go into more detail. So for the workup, what do we do? First of all, everyone needs a complete eye exam. And you need to ask yourself, are there comorbidities that could result in a suboptimal outcome? Every cataract patient needs to have a good axial length and keratometry measurements. And I would say this is the time to invest in a good biometer and use modern IOL formulae. Meaning the new formula are much better than they were 5, 10, 15 years ago. If you have a very dense cataract, use an immersion A scan to verify the axial length. And it is very important to track your outcomes. We track outcomes for every patient, not just our premium lenses, because we do need to make adjustments on, you know, over time. And so you don't know how you're doing unless you track your outcomes. And that's a whole other lecture in itself, but it's really important to do that. Every patient needs corneal topography. You really want to check for irregular astigmatism. And I do believe every patient needs a macular OCT. Unfortunately, I've been burned by this in the past where a patient has what looks like a very non-visually significant epiretinal membrane. And sure enough, after surgery, it swells up and they've got macular edema or there's vitreomacular traction, and it becomes a problem for the patient. They can't see as well. And there's the saying that if you diagnose it before surgery, it's their problem. If you diagnose it after surgery, it's your problem. And it is very important to identify any macular pathology before the surgery. So we do macular OCTs on everyone. Determine your workflow. This is probably the hardest thing in our practice. Sometimes we don't know a patient's coming for the cataract visit. So we do bring them back for their biometry measurements. We do bring them back for some counseling. If we know that they're coming in for a cataract evaluation, sometimes we can get the data ahead of time. And then it's very nice in one visit to be able to counsel the patient and offer them lens choices. We do the same thing on every patient. Patients change their minds quite often. So the patient may tell you, oh, I don't want a premium lens. And then a week before surgery, they're calling up saying, oh yeah, I really do want the multifocal. And so we do everything on everyone because it's difficult to bring them back to do the macular OCT or to do the topography. We want to make sure we have all the data on hand for patients in case they do change their mind. And if you can send information out prior to the visits, very helpful. So we send the patient a packet of information if we know that they're coming in for a cataract evaluation so that they come in informed about their choices. It's very helpful to have a discussion about a multifocal when someone comes in saying, I read about the multifocal, I'd really like to learn more about it. So rather than starting from scratch, they have information ahead of time, and that can be very helpful. So questions to ask yourself and the patient is A, does the patient desire spectacle independence? Many patients think they may be happy to wear glasses, but most, when asked, would love to get rid of the need for glasses, and they may not even know that that's an option for them. That being said, they need to understand the limitation of the lenses they are choosing, distance versus near versus multifocal. A lot of times we'll say, I can do distance correction, but you're going to need reading glasses. And they're going to say, I can read without my glasses now because they're a -2. And then you have to discuss the fact that they're not going to be a -2 anymore. So this can be complicated for patients to understand. So it's important to have that discussion so they know the limitations. Is the patient a good candidate? Like I said before, you want to look for things like macular degeneration, glaucoma, severe dry eye or ocular surface issues, or irregular astigmatism. None of these are absolute rule outs for different lenses, but it needs to be involved in the discussion. If a patient has significant macular degeneration, you may not want to do a multifocal, but a toric could be appropriate. Same thing with glaucoma. Severe glaucoma could be a rule out for multifocal, but a toric could be appropriate. So things like that need to come up in the conversation. And then you have to talk about what are the visual needs of the patient. Are they a -2 and do they work at a desk all day staring at a computer? Maybe you want to leave them a -2. But patients who are active, they may want to give up a little bit of their clarity at all distances in order to achieve vision, a broader range of vision. Do they have strabismus or another need for glasses post-op anyway, which would preclude them from using a multifocal perhaps? Are they monocular? I don't tend to use multifocals a lot in monocular patients because I don't feel like they get the full benefit of the lens. But these are all things that you need to consider. And using a vision simulator, different devices or different books can help simulate what patients can expect with different lens options. It is important to talk about they may lose some contrast sensitivity. I've never seen this to be a clinical issue with multifocal, meaning no patient has ever come back to me saying, hey, I've lost some contrast. But this is something that some patients will bring up because they read about it. We did a study several years ago that shows that patients may need a YAG laser capsulotomy earlier with a multifocal because I think they do notice subtle changes with PCO that may not necessarily bother them with a monofocal lens. They will get some glare and halos for sure. They'll get that with a monofocal lens too. But I talked to them about the fact that they're going to notice it more. It gets better with time. I've only had to exchange 4 multifocals in almost 20 years, and none of them have been for glare and halos. As long as you tell the patients ahead of time, I haven't had a patient be so frustrated with the glare and halos that they want to give up the benefit of the multifocal because of the glare and halos. And they really do get better with time. By 6 months, I ask the patients, how are the glare and halos? And the patients say, I notice the glare and halos, but they're not bothersome to me anymore. I don't notice them as much. If I look for them, I see them, but they're not bothersome. And it's important to really talk about patients who have dry eye and ocular surface disease issues to try and improve them as much as possible prior to and after surgery. With a toric lens, there's almost no downside to correcting astigmatism. We know that more than a half diopter degrades what patients can see without correction. But the key with the toric lens is to make sure the refraction, the topography, and the keratometry all match, meaning just because you see numbers on a keratometry reading that says they have a diopter of astigmatism, but if their topography isn't showing it and they're not showing the refraction, you may not want to put a toric lens in. And sometimes they'll show it in the refraction, but not the topography and the keratometry. But if the topography and the keratometry match, you can sometimes assume that there may be some lenticular astigmatism in their refraction, and that may be causing some of the mismatch. But I really look for matching between the topography and the keratometry, and making sure that the astigmatism is regular. You have to beware post-RK patients. If you have a post-RK patient that is very regular astigmatism, then I think it's reasonable to do a toric lens. If they're very irregular, I wouldn't recommend it. If they are contact lens dependent, if they're keratoconus that are contact lens dependent, then I would not use a toric lens because it makes the contact lens fit more difficult with a toric lens inside the eye. But non-contact lens dependent keratoconus patients who have mild keratoconus that can be corrected with spectacles can do well with toric lenses. I would suggest running the calculations. This is a toric calculator. It will tell you, what the residual astigmatism is going to be, whether or not the axis is going to flip, and then you can make your decision. And it's fun to just run these calcs sometimes and run different scenarios. This is an LRI calculator. Again, just running the scenarios can be very helpful because sometimes a patient may be on the fence for an arcuate incision or an LRI versus a toric lens, and you can see which one you think might do better. Again, tracking your outcomes is important. We have better outcomes with toric than with LRIs. It's just the way it is. Torics, I think, are more precise, but we do LRIs for the lower power astigmatism corrections. Other considerations, with premium lenses, I think one of the obstacles and why some surgeons are reluctant to enter this realm is the need for enhancement. Hopefully your enhancement rate is low. Our enhancement rate is around 1 to 2%, but you need to be able to do an enhancement or have a way to get the patient enhanced. Meaning, if you're not comfortable doing laser vision correction, specifically PRK, then you may want to partner with someone else who can help you in those circumstances. I don't think it's a reason not to do premium lenses, but you do need to have a reason, a way to enhance these patients if you're off a little bit. There is the rare possibility of rotation of toric lenses. I don't think it's very often. In fact, if you wait for the lens to fully open up before removing the viscoelastic, I think the rate of rotation is low, but sometimes it does happen. It's important to talk to the patient. Sometimes patients think paying more means better quality. Well, it does mean better vision quality, but the quality of a monofocal lens is still quite good. So it's important that they understand that, because if they don't qualify for a toric and they need just an LRI, they're still getting a high quality lens. And so We see that in the US a lot, where patients think paying more means better quality. Paying more for a multifocal or a toric means better quality vision, but the quality of the lens material is going to be quite good no matter which lens you use, and using a multifocal or a toric for that matter. But for the majority of the post-LASIK patients we see here in the US, a lot of them do quite well with multifocal lenses, and they do, and they're very, very happy patients. You know, traditionally we would have very dense cataracts, patients with white cataracts or very brunescent cataracts, and would never have the premium lens discussion. But nowadays we do, because patients are coming in asking that. And so very dense cataracts are not necessarily rule outs for premium lenses, and we want to have the conversation with them. In addition, we do use aberrometry that can help fine-tune the calculation. We don't use it as much anymore because what we found is with the newer biometers and the newer formulae, they're so accurate that aberrometry doesn't really change our mind much, but we are using it in post-refractive patients kind of as a belt and suspenders approach to try and just fine-tune our calculations a little bit while the patient's on the table. Just a few more minutes, I'm going to go through beware of potential obstacles. You know, as we know, these calculations have to be very precise, and lesions such as pterygia, Salzmann's nodules, they can all induce changes in the cornea that can affect your calculation. Other things like conjunctival can be a factor. You know, you want to make sure the ocular surface is cleaned up as much as possible before any cataract surgery, but especially with premium lenses. So if a patient has significant conjunctival, you may want to consider a conjunctival resection or cautery prior to surgery. Eyelid laxity can be an issue post-op with irregular ocular surface wetting. So you want to make sure that you look for ectropion. Ask the patient to blink, look at the lids. Do they have a lot of exposure? Do they have any type of thyroid eye disease? Things that could result in a poor visual outcome as a result of the exposure. Things like EBMD is one of the more common things we see. And I do have patients with multifocal lenses with EBMD, but occasionally I will, depending on how bad it is, I will go ahead and clean up the ocular surface. I will do an epithelial debridement with a diamond burr polish, let it heal in, wait 4 to 6 weeks, and then go back and remeasure the patient for their IOL calculations. And this obviously can be exacerbated by dryness, and it's very helpful to show the patient. We'll photograph the patient and show them the picture so they know exactly what we're dealing with. I find if a patient has a photograph, it makes it much easier for them to identify the issue and to take ownership of the issue with us to help solve the problem. Things like convergence insufficiency. If the patient has issues and may need prism afterwards, then maybe a multifocal isn't the best option, but it can be under the right circumstance. As we mentioned, pterygia. Obviously, if you have a pterygium like this, that's going to induce some astigmatism. Same thing with Salzmann's nodules. And I just want to show you a case. You know, obviously we want to check the topography, check the case. Doing manual keratometry can be very helpful in this situation to look at the irregular mires. Placido disc topography can also be very helpful. And you want to say, is it growing? Is it currently causing a change in vision? And will it be in the way of the surgery? This is a case of a 58-year-old man with a primary pterygium, and you can see his preoperative refraction here, and his preoperative IOL master was not readable. Here's his topography, and he had a total of 4.42 diopters of irregular astigmatism. Here's his 1-week post-op visit, and his K's changed significantly. And so what happened here was he has a total astigmatism of 2.69 diopters. The difference in astigmatism after 1 week was 1.73 diopters. So it was a 39% reduction in astigmatism. And that turned out to be the difference between a 21 diopter lens and a 22.5 diopter lens. Now, not all cases are this dramatic, but if you're thinking about premium lenses in patients who have ocular surface issues, it is important to try and consider things like this. In fact, I had a patient recently with Salzmann's nodules who did not want a superficial keratectomy prior to surgery in one eye, and he had significant astigmatism, and we put a toric lens in. His astigmatism looked fairly regular, but the Salzmann's nodules are still affecting his vision. Now I have to go back and remove the Salzmann's nodules. So I probably should have pushed him a little harder, but he didn't want to miss more work, and so I didn't. And now I've got to go back and remove the nodule. But here's another case where we have a total astigmatism of 4.2 diopters, and the difference after a week was a 25% reduction in astigmatism, which resulted in a difference between a 16.5 diopter and a 17.5 diopter lens. So I do recommend excising corneal lesions as much as possible prior to surgery, letting it heal, and then going back and redoing your calculations. We're almost out of time. So in summary, premium lenses will be, premium IOL patients will be some of your happiest patients. Don't be afraid to start using them. They are great lenses that, don't feel bad about using them or about having to ask the patient to pay out of pocket. Patients are very grateful for these lenses. It gives them freedom from glasses that they've never had in their life. Reach out to others if you need guidance. If you're new at using premium lenses, there are many of us out there that are absolutely willing to help you. Start with easier patients. Start with a patient who doesn't have much astigmatism. Hyperopes, like myself, are great patients to start with multifocal lenses. But it is always important to perform meticulous preoperative examinations and testing. And as the development of improved IOLs occurs over the next few years, this will lead to even better visual freedom. So I really thank you for the opportunity to speak. I think we're going to have a discussion now. I apologize for the screen freezing. I'm not sure what happened, but really appreciate the opportunity to speak with you today. Thank you very much.
Thank you very much for this lovely presentation, sir. It was a really eye-opener for most of us. Okay. How do you manage when a patient has a monofocal IOL in one eye and then wants a premium lens or like a multifocal in another eye? Do you go ahead with it?
So you're asking about multifocal in one eye and wants a monofocal in the other eye?
No, the patient already has a monofocal in one eye and then wants a multifocal.
Monofocal in one eye. Yeah, I don't encourage it. I've done it before. I tell the patients, I don't think you're going to get the full benefit of the lens. And some of it depends on the dominance of the eye. If it's their non-dominant eye, they may get a little bit more range of vision. They may get a little bit of near vision. So I'm not completely opposed to it, but I do tell the patient, you're not going to get the full benefit. I personally feel like these lenses work best when you have them in both eyes, just the way they're designed and the way our binocular vision system works. So I think with the proper counseling, it's reasonable to do, but the patient really needs to understand they may still need glasses, for prolonged reading, prolonged computer use. It may allow them a little more freedom, like to look at their phone, but it may not give them complete freedom. And with a good multifocal or trifocal lens, I group them all together, or EDOF, we're seeing about 85 to 90% of our patients never using glasses. About 10 to 15% need it for some activities. Dr. MIRLAY, are you noticing the same thing as with your multifocal outcomes?
No, we have a little different method here. The biometry accuracy at my place is about 95%. We track the biometry for every one of our patients for the last 8 years. So the accuracy overall for monofocal as well as multifocal ranges from about 95 to 98%. Because we have five methods of cross-checking the IOL master. The IOL master remains the primary thing, but we have 4 other cross-checks which we use, and we use them with great accuracy for mature cataracts as well as where the IOL master cannot give you a reading. We have developed our nomograms for that. So our confidence is very high. We promise our patients glasses-free vision for 100% of all our patients, with the caveat that they will not require the glasses for more than 5 to 10% of the time, or in 5 to 10% of the patients. So we have hardly any, so we have this escape route to say that we will prescribe glasses for you after 14 days, but the number will be very small and you may or may not require to use it. So this way we avoid any enhancement requirements because there's no promise upfront of glasses-free vision, 100%. Our promise is glasses-free vision, 90%. I'm talking distance.
How about you, Dr. Sir, in your practice? How about your practice, sir? Like how do you see how do patients receive premium IOLs?
We do about 30% of the list is premium IOLs. We've been doing that all along. Nowadays, because I operate in a certain area of Bangalore, they ask for it. So you did this 90,000 rupee surgery for my aunt. Now, can you do it for me? And my mother-in-law, you did this. Can you do? So they ask for it. But we tell them that the premium IOLs are much cheaper than the monofocal IOLs. And we explain to them how. So if you charge, say, 75,000 for a multifocal Lisa, non-toric, and we promise them glasses-free vision to the extent of 90 to 95%. So when we tell them that you will probably require 2 or 3 pairs of progressive glasses in a decade. So if you're 60, you might require about, say, 4 or 5 pairs of progressive glasses. Now the cost of that is much more than the difference between, say, 75,000 multifocal and, say, a 45,000 monofocal. So we tell them that it's a little more expensive initially, but it works out much cheaper in the long run. So we have multiple technologies for marketing. We have surgical coordinators or counselors who are specially trained in them. So as Dr. Richard mentioned, that a lot of chair time is taken. We spend about 2 hours chair time, but I don't spend the time. The surgical coordinators does it. So have I answered your question?
Yes.
Dr.
Yeah.
Prathiba?
I have another question from the audience. What if I don't have an IOL Master 700 and then the patient still wants to go for a premium IOL? Then what do I do?
For whom is the question?
It's for all
I
three
guess
of us.
any of us. We can all take that. Yeah, go ahead. You start, and then we'll take. Yeah.
Dr. SAMARESH can answer that.
Samri?
Yeah.
I think it's a very valid question, because most practices in India will not have an optical biometer, and I think that's not even an issue, because immersion biometry is pretty bang on. Optical biometry has a distinct advantage in terms of more accuracy, like to get results like Dr. MIRLAY's. But even otherwise, with a good immersion biometry, good technique, a good technician, good keratometry readings, I don't think it should be a caveat, or it should be a problem in doing premium IOLs. More importantly, I would say if there is a choice, one should have a topography to get regularity of the corneal astigmatism, because you don't want astigmatism playing bad role in your IOL power calculations. So it's always good to have an optical, in my understanding, but if one doesn't have, for the time being, immersion biometry will be a pretty valid thing to do.
Dr. Richard?
Yeah, I agree. I think obviously first choice would be to have something like an IOL Master 700, but a lot of places can't do that. But getting good at immersion is a valuable skill. We still do immersion, because we have very dense cataracts, and some of them can't measure on the IOL Master. So we do immersion on some patients, and it's quite accurate. So the key is really making sure that they're trained properly. And I agree, having a topographer is very, very helpful. The advantage of having something like the IOL Master 700 is just overall better accuracy, getting posterior corneal readings, total keratometry, things like that, being able to automatically plug in more complex formulas. You can do that without the IOL Master, but it is just more complicated and more manual labor for you to run the calculations.
Sir, Dr. SAMARESH, how do you choose your lenses, sir? I mean, is it totally only the patient decides, or do you think, apart from the fact that drivers, we don't advise multifocals, you prefer an extended focus lenses, or you prefer multifocals for your patients, sir?
So again, madam, that's a great question. In our practice, I have a fairly young practice. It's only about 8-9 years old in private practice. And I did face my, teething issues with multifocals and premium IOLs. But what I realized is that at the end of the day, if you understand the patient's lifestyle and their requirements, and I think a patient, at the end of the day, like Dr. Richard brought about, it's the patient's choice to decide the lens. So we don't discuss economics of the lens and the prices at all with the patient. And we discuss the lenses in terms of the benefit and lifestyle and the vision they will give. We leave the financial discussion to the end of the counseling to be done with the financial counselor, so that they can absorb in reality. Because as they are aging, as these patients are normally old, and as they're aging further, there are going to be multiple issues. There are already health issues, and any independence of glasses, which is another hurdle into their quality of lifestyle, is something they can avoid right now if they choose a right kind of lens. So I don't push a lens to a patient, but I explain all lenses, considering if they're suitable for toric. I am very aggressive with toric lenses, because I believe they will add a lot of freedom in the patient's distance vision. Multifocals, I leave a choice to them. And it's surprising that most of the patients who you don't pin down as patients who will choose a premium lens are the ones who opt for it first.
Yeah.
Is there any contraindication for premium IOLs, sir? You said, Dr. Richard, you said most of these things can be managed, but is there one particular, contraindication? No, this patient, apart from an, unrealistic patient. Unrealistic patient is a different thing, but from the ocular side, do you have anything like in this particular condition? No, I will not implant a premium IOL.
I'm sorry, you broke up a second. Was the question, which patients would you not use a premium lens?
Yes. Is there a particular contraindication? No, I will not put a premium IOL in this patient.
Yeah, I mean, I really, I'm much more cautious with post-RK patients, you know, but just because of their multifocality of their cornea to begin with, and the fact that their astigmatism tends to be irregular. I have put some toric lenses in very regular, low-cut RK patients, but in general, I don't. I just put a monofocal in, and actually, they do quite well. Most of the patients are in the 20/40 range post-op and have some multifocality because of their corneas. So those are the ones that I tend to stay away with. Obviously, anyone with significant macular disease, I don't put a multifocal or trifocal lens in. But for the most part, you know, I would say the RK patients. I don't know if you all have similar experiences.
What about you, sir, Dr. Ram?
Yeah, we have a very different method of contraindications for multifocals, and we call it the two-question rule. TWO, two-question rule. So we explain about lenses in general and about multifocal in particular. If the patient asks more detailed questions on the multifocal lenses, if he asks a third question, then he's immediately contraindicated for the multifocal lens, because this is how we identify the very exact and demanding mindset personality patients. Now, let me go a little more deeper into this. A person who comes to you with a whole set of questions in his hand, or who's read the internet, will ask you a number of questions. Now, such a person is a very exacting, accurate scientific personality generally, and he is not going to accept a compromised vision, which is what the multifocal lens offers. The multifocal lens, and I use the Zeiss Lisa, it cuts down your distance vision illumination by 35%, because that much light is gone for near vision. Add to that, so which means you have a slightly reduced contrast sensitivity, which as Dr. Richard mentioned, it really doesn't matter. I agree with that. But the glare and halos in the dysphotopsia and his low range of near vision, there is a compromise and a learning curve which the patient goes through. And a very scientific, educated mindset, a non-compromising kind of a mindset, for example, an ophthalmologist would be unlikely to be happy with this. And how do you discover all this? We have this simple rule. Third question comes, we write there, monofocal preferred. And that's the way we step out of post-operative headaches.
What about you, Dr. SAMARESH? Do you have any particular contraindication?
I think, madam, there are two different lenses we are discussing here. When it comes to the multifocal lenses, I would agree, but I'll discuss a toric lens first. I don't think toric lens is really a premium lens, because, you know, it's a monofocal with just an added toricity. And my criteria for toric lens are far more relaxed. So as long as the patient has a regular astigmatism of a treatable value, I do not err down on you know, advising toric lens to macular degeneration, glaucoma patients, patients with any visual condition, because it will only add to their quality of vision. When it comes to multifocality, my threshold, I mean, like both the doctors brought about, personality matters, but understanding the nature and explaining the cons of the compromises very clearly to the patient. I do advise multifocal to most patients where I do see the OCTs of absolute normalcy, and there's no other comorbidity in the eye. The slightest comorbidity in one of the eyes also, I do not even tell them about multifocality at all.
I agree with Toric. I think Toric is a very easy discussion because you're only going to make them better, and it's really a very added value for the patient. And I like the question thing. Although I will say I have had some very type A patients with lots of questions turn out to be very good multifocal or trifocal patients, but it is a lot more chair time and a lot more work. I mean, I can think of times where I've spent many, many minutes and lots of correspondence back and forth prior to them making decisions. So I like your process there.
Thank you.
How do you handle unhappy patients? This is for clear view.
What's the question?
How do you handle unhappy patients?
Great question. Yeah, I mean, I think first you have to figure out why are they unhappy. I mean, I can think of specifically a couple patients in my practice who I walked in the room and they were very angry at first. And this was like a week after surgery. Sometimes it's after the first eye and you haven't done the second eye. So you have to figure out what the problem is. A, did you hit your target? You know, if I hit the target, I'm not worried. And then I tell the patient, you know, this is just the first eye. And I tell patients ahead of time, I don't think you're going to get the full near benefit till we do the other eye. And so you have to be willing to do the other eye, I think. You know, you'll have great distance vision right off the bat, but I don't really feel the intermediate and near is as good till you do the second eye. So that's one thing. The second thing is sometimes patients heal a little longer. They have some irregular astigmatism afterwards, either from ocular surface issues or from dry eye or from the incision. So I say, you know, give them time. And then what I tell them, just to kind of calm them down, is there is nothing we can't fix. I said, yeah, this is a fixable problem. And I think you kind of have to diffuse that situation, because some patients do get very emotional about this. They've spent extra money, they're expecting perfection, and all of a sudden things are off. And I use the analogy, I said, look, you know, you had a very dense cataract and we took the cataract out. You're going to have some swelling. You know, I've had patients in tears on post-op day one because their vision was like 20/40 and they feel like we've used the wrong lens. So I think a lot of it is just setting expectations, speaking to the patient, and reassuring them, like, look, we're going to fix this problem if we need to, but I tell you, chances are there's a 99% chance we're not going to have to do anything. And I think that calms them down quite a bit. If they're truly unhappy, you know, then you deal with it. You can do a lens exchange or things like that. But I think that's very, very rare in most practices. I don't know if you all have other experiences.
How about you, sir, Dr. SAMARESH? How do you manage?
I think I totally agree. When an unhappy multifocal patient comes, if it's within a 2-month time frame, I just let them ease out. I put them at their comfort zone, telling them nothing is wrong. But I would do all investigations, including aberrometries, topography, and an OCT, because I don't want to miss out on anything, you know, gross, which probably sometimes in very dense cataracts and mature cataracts, you really can't see the maculas. And those are the patients where things can happen. But if otherwise, I haven't in my practice, I've not explanted a single lens. I had a patient who came to me elsewhere with a multifocal IOL, Restore +3, and extremely unhappy. Or a small pupil looked absolutely okay, but the moment I dilated, one of the haptics was in the sulcus, the other one was in the bag. And there was a huge comma aberration coming from the eye. So sometimes it's also a badly done surgery, you know, and unfortunately the lens gets the blame. So one has to look at probably everything before doing, you know, taking a big step like an explant.
Okay, surgery has not gone well. You have a problem during surgery, and then how do you counsel the patient post-operatively when the results are not?
If the surgery's gone bad?
Yes. How do you?
I mean, I don't know. There's different options. You know, obviously, if you don't have enough capsule support for a multifocal or trifocal lens, that can be challenging. We do have options for 3-piece lenses that are multifocal. And that is an option to perhaps put a lens in the sulcus or perhaps do other types of scleral fixation techniques for the multifocal. I think these circumstances are very, very rare, but it could happen. That is definitely, in speaking with other surgeons, one of their biggest fears about doing a premium lens is the fear of tearing the capsule. So you definitely have to be a pretty proficient surgeon. But I would say for most surgeons, the rate of capsule tear or not having enough capsule support is pretty rare, but you should have a backup plan involved. And there are circumstances where you have to tell the patient, you know what, we couldn't do this lens. It's not appropriate for your eye. And we didn't know that till we started the surgery. But I don't know if you all have other opinions about that.
An audience question, sir. Dr. Ramley, do you advise premium IOL in diabetic retinopathy patients?
Can I comment on the previous question a little bit about the unhappy patient?
Yes,
okay.
sir.
When an ophthalmologist examines a patient, there are 2 parts of the examination. The first is called the history, and the second is called the findings of the examination. Now, it's only when you botch up and make a mistake or a blunder or omit something in these 2 steps that you create an unhappy patient, assuming that the surgery goes fine. So A, B, C. A, there's a mistake in the history. You've chosen the wrong patient. B, you've missed a finding like a squint or a macular, whatever. Then you have an unhappy patient. Or C, you botch up the surgery. In fact, our language is very defensive. it says the posterior capsule ruptured. We don't say I ruptured the posterior capsule. There's no ownership here. It's a very defensive kind of a thinking. So premium IOLs is for premium skilled surgeons. It's not for every surgeon. And that probably explains the Dr. Richard's comment why only 20% of the people in the United States are using it. Probably these are the top 20% in skill. The others can probably get away. So that would be my comment on that. Now there are 5, this is the only surgery, I'm talking multifocals largely, as Toric, as I said, is part of a monofocal kind of a workup. It's only in multifocals that you can have 2 complications of surgery before you start the surgery. 1, your biometry is wrong and you don't know. And 2, you've chosen the wrong mindset of the patient and you don't know. Both are correctable pre-op. So once you've got into this problem, just because you're not thorough enough, you pay a price. So I would say that multifocal surgery is only for those surgeons who have an extremely low PCR rate. And if you have a single complication in surgery, like a PCR or anything, I always abandon the multifocal and put in a monofocal sulcus lens and refund the balance difference in money. So that's my way out, because end of the day, I need to be sure that I've done a good job for the patient. Now, can I take your second question? What was that, ma'am?
Would you recommend a multifocal in a diabetic retinopathy patient?
If the macula is normal, OCT and the retinal photography is normal, then yes. If there is any macular involvement, then it is a yes and a no. So let me explain the controversy there. If a person is an elderly gentleman who's homebound with minimal early, if there's advanced macular disease, then I don't put a multifocal. But if there's very minimal macular changes and the patient is a homebound patient, maybe substantially elderly person, then a multifocal has advantages in him. He will need low vision aid at some point of time, and my +3 or 3.5 add inside the eye will help his external low vision aid. On the other hand, if the person is more utilizing his long distance vision, is an ambulatory patient, then I prefer a monofocal so that he does not have a contrast sensitivity handicap for long distance. However, if you want to be very safe, a monofocal is a non-controversial option.
One more question from the audience. Post-trauma, would you prefer a multifocal or a monofocal?
Post-trauma, for me, it depends on how bad is the trauma. Obviously, is there a big corneal issue? What's the status of the iris? What is the status of the capsule, the retina? It just depends on the trauma. We've had some patients absolutely with very not minor trauma, minor looking trauma, meaning intraocular foreign bodies that have gone into the lens that are self-sealing wounds that we remove the IOFB, and they're otherwise healthy eye, and they're young patients. I've absolutely put multifocals in them or trifocals. If it's a huge trauma that's required a major surgical repair, I've tended to steer away. I've not put any multifocals in anaritic patients or patients with artificial iris, things like that. I don't know if you all have any other experiences with that.
It's only a traumatic cataract with no other corneal involvement. What would you prefer, Dr. Samaresh?
I think Dr. Davidson's point is very well taken. If the lens is not going to be well centered by any means, suppose you said it's not a corneal involvement and sort of a blunt trauma, it could be a zonular loss and the lens could decenter. In any case where there is a compromise in the capsular bag in terms of zonular laxity, I would err away from putting a multifocal lens. Or if the pupil is fixed dilated or irregular or drawn to one side, it's going to add problems. So very, very few sort of trauma cases I would probably confidently go ahead and counsel a multifocal IOL. Most of them I would probably hold it aside.
Question from the audience. Any other way of calculating toric IOL power apart from being online?
Yeah, can I take that, or would I request Dr. Davidson to and Dr. Samaresh first?
No, go ahead.
This is an area we have a lot of data. Go ahead, Dr. Davidson, please.
Okay, so the question was other ways to calculate for toric lenses? Yeah, I mean, you could use your own nomogram for sure. I've never done that. I've always done the online calculators, but we've run different calculations depending on different types of lenses that we use, meaning, we use 2 different brands of toric lenses here in the US in our practice. And so we've run it, I like to look at the calculations based on different nomograms and just run it through that. But I've always used the online calculators for the toric lens. For LRIs, it's different. And in days past, before we had good post-LASIK calculations, we used to do all the calculations manually. So I would have a page of calculations, not just for toric, but for regular monofocal lenses. Ram, did you want to add something to that?
Yeah, can I? So in our opinion, the online calculators are not very accurate, especially those provided by the company, which is Carl Zeiss and Abbott. That's my opinion. That's our experience. They're sometimes accurate, sometimes not. So they're not 100% dependable. The one design defect that I find, which the companies do not agree with, manufacturing companies for IOL master, is that lenticular astigmatism is not picked up. Total astigmatism is picked up by the instruments. Now, I've had cases where lenticular astigmatism plays a significant role in the measurements, and that is suddenly absent post-cataract surgery. So we have, this happened quite a few times for us about many years ago. So we have a method. We use a normal, non-intelligent Javel-Shiot's keratometer to pick up the corneal curvatures accurately. And then we take the axial length measurements from the IOL master, and we calculate the IOL power for the steep cornea and for the flat cornea separately. Based on these two, we calculate the astigmatism and use the base power of this intraocular lens as that which we get from the flat corneal measurement. So we have the flat corneal measurement to tell me the base power of the lens, the main dioptric value. The difference in power will be the cylindrical value. We use this as our standard method for torics as well as toric multifocals. In addition, we have other inputs which has to correlate. The other inputs are not very accurate, but they all contribute to increasing the overall accuracy. We have a nomogram to decide the power of the eye of the intraocular lens based on the spectacle power. So spectacle power is 0, then one would expect that the intraocular power may be in the region of 21. Then we have a nomogram for comparing the left axial length with the right axial length. And if the difference is more than 0.3 diopters or 0.6 diopters, sorry, that's more than half a millimeter, then again, we recheck and redo certain values. So we have quite a laborious, painstaking method of doing it. And we approach the axial length from different angles. So together, it gives us an overall accurate result. We have not much experience with immersion biometry because I think we had some bad experience. We probably could not skill up. And it depends on the skill of the person. And we have 4 optometrists in our office. And each one may have a different thing. And we felt it's a little messy. Whereas our this roundabout method has been working very well for about the last 10 years, 8 years, sorry. So we're very comfortable doing that, and we promise glasses-free vision. And we undersell and over-deliver both the marketing part as well as the vision part. So all our enhancements are in terms of spectacle prescription. Thank you.
I like that. I think that's great. It's really, really good. Very impressive.
Thank you. What about you, Dr. SAMARESH? What kind of formula do you use? Or?
I rely almost, like Dr. Davidson brought about, initially in my fellowship days, I used to have a whole page of all the keratometry readings from the topography, from the aberrometry, from manual K. We use the Javel-Shiot's as well. But now I just look at the Barrett toric calculator, and I am mostly within a half diopters of my target. And one can use a non-company Barrett toric calculator, which is available on the APS-CRS website for free.
Yeah.
But for me, that works like magic. So I stopped looking at most numbers, and I look at the numbers, but I rely quite comfortably on the Barrett toric calculator now.
One more audience.
Yeah.
What is your take on Technis Eye-Hands IOL? Dr. Richard?
I'm sorry, I didn't hear the question.
What is your take on Technis Eye-Hands IOL?
The Technis IOL, is that what you said? Sorry,
Eye-Hands.
Eye hands?
Yes. Have you used it?
We don't have that lens in the United States. It's called the eye hands.
Yes. What about you, sir, Dr. Ram?
Yeah, I used quite a bit. This is offered as the premium lens in the monofocal segment.
Okay.
Now, it is marketed as EDOF for extended depth of focus, and the theory which which shows bending rays of light goes against all logic of optics. However, the lens actually works, and it gives us approximately for a 6/6 vision where the calculations are correct, patients do read N12 comfortably in normal light. So it delivers what it claims. However, it doesn't fit in, it doesn't give you N6, so we can't call it as a multifocal. But the major advantage with eye hands of Techness is that it is there are almost no glare and halos. It's on par with monofocals, so we offer it as a premium monofocal lens.
You have used it, sir, Dr. SAMARESH?
No, madam. I mean, I've used a similar category of an intermediate vision lens, the Restore 2.5, which essentially is a similar thing. I think the biggest advantage with these lenses is that the center is distance dominant, so your distance vision is like a monofocal, like Dr. MIRLAY brought about. And because it's a fairly larger zone, you don't get those glare and halos. So there is a small population that may benefit from these lenses. But with the coming of good trifocal lenses, I think the sect is quietly sort of shrinking up now.
Yeah, we've had great success with trifocal. I've not seen the glare and halos to be bad at all. The trifocal has been great range of vision. By far, in my practice, the trifocal has been the best so far as less glare and halos and definitely more range of vision for sure.
One more audience question, sir. Which IOL formula do you prefer? Dr. Richard?
Sorry, can I answer? Can I add to Dr. Samaresh's point, please? Yeah. Dr. Samaresh, does your Restore 2.5 have rings that you can see?
Again, it depends, sir. In most mesopic conditions, I can see one.
So there are rings in the lens, whereas in the EDOF lenses, there are no rings in the eye hands.
Yeah, that is true.
So that's a critical difference that we can make out, because since we have not had lenses in our eyes, we are at a loss to tell from personal experience. We can only tell from patients. I'm done. Go ahead, please.
So the question was, which one do I prefer?
IOL formula, yes.
Which lens do I prefer?
Which IOL?
Question? Yeah, so I've used them all over the years, and it's been an evolution. I started off with Restore, and I have some very happy Restore patients. I then switched to Techness multifocal, have some very happy Techness multifocal lenses. Used Techness Symphony for years, but currently I'm using PanOptix. In my practice, the PanOptix has given us the best range of vision with the fewest ocular side effects. Very little or tolerable glare and halos. And it's been very nice as far as the freedom from glasses. Definitely by far the best I've used so far.
One more audience question, sir. Multifocal in post-LASIK patient, how do you calculate the IOL power?
You guys want to take that?
Go ahead, sir.
Or I can take it. In post-LASIK, I do quite a few in post-LASIK patients. I think they need to be counseled properly. They've already lost some contrast from their LASIK in most cases, and so they may lose a little bit more. Again, I've never had a patient tell me they lost contrast, but it can affect quality of vision. I tell them they may give up a little bit of quality to get both distance and near, but a lot of these patients, having had LASIK, are very motivated for spectacle independence, and so they're willing to tolerate some differences in their vision in order to get more range. And I think the key, as I mentioned before, is making sure their corneal astigmatism looks regular, that they don't have an irregular flap or some kind of irregular ocular surface that's going to result in a suboptimal outcome from a trifocal or multifocal lens.
How do you calculate the IOL power in lens, sir? Any particular?
For the IOL power, we're still using the Barrett. We're using the IOL Master 700 with the Barrett formulas, and we can check it with CRS formulas too, but we found it to be very, very accurate. We will sometimes do Aura, but we are actually about to publish a paper that showed Aura didn't really change our mind very much, and so we've not used Aura as much anymore. I don't think Aura hurts, but we found with IOL Master 700 that we've been on target, very well without having to really modulate anything from a calculation standpoint in the post-LASIK patient.
Thank you, sir. Dr. Ram, how much do you depend on your counselors for this, for premium IOL counseling, sir?
Tremendously and totally. I don't counsel the patients at all. We have a whole separate training for multifocal counseling. We don't mix them up with the regular counselors. And we have at least minimum 2 sessions of counseling, even if they are convinced at the first session. We have a whole training program for them, and it takes them at least 6 months for a good counselor to upgrade and graduate into multifocal counseling.
What about you, Dr. Sandesh? Do you also depend on the counselors, or do you do the counseling yourself?
Madam, mine is exactly the opposite right now. There's one point before I add on to this is Dr. Davidson brought about a very important point that I do all my pre-ops at a separate time. I call all my pre-ops in the afternoon when the clinic is at the quietest. So I have all the time, chair time available to me. And all the counseling regarding multifocal, our counselors were doing up until 2-3 years back. But now the consultants have started doing exclusive counseling. So we've separated the financial counseling from the lens counseling. So we counsel the patient about the benefits and the disadvantages of the lens. And then the patient gets a financial counseling by the counselor. But the scientific counseling we've taken away from the counselor's hands for now.
Okay, one final question for all three of you, sir. If you do have a cataract and you do have to go for surgery, which lens would you prefer? Dr. Richard?
I'll start. Yeah, I would take a trifocal in a second. I'm hyperopic. It drives me crazy to be hyperopic. I'm a plus 5.5 diopter hyperope, so I would do a trifocal. And I've actually thought about it because now I'm presbyopic and it's been driving me crazy. So I would definitely do a trifocal lens.
Okay. What about you, Dr. Samresh?
I'm a little far behind in the race right now, so I think we'll get an opinion on the other side.
So people like us are looking at.
I think I'll go for a trifocal as well, madam. I think the advantages far outweigh the disadvantages. So for me, it's a trifocal for now.
So Dr. Ramwale, sir.
I'll go for an EDOF lens and not a multifocal, and I'll tell you why. Those who have exacting visual demands in their mind would not find the contrast sensitivity drop acceptable, and it's a compromise. So I learned this the hard way when I operated upon some scientists, and they said, Dr. MIRLAY, it looks like I'm wearing a tinted glass all the time. Okay, so what is bright is now slightly dull bright, and what is dull is very dull. And it's true that they get used to it. So this is what happens when you operate on younger patients, say in their 50s or 60s or even up to 65, 70. The senile age group, it's word is used in a technical sense, the 70 plus age group have anyway very reduced contrast sensitivity due to the aging process. And so they may not feel the extra contrast sensitivity loss so much more is what I feel. The EDOF lens, best of my knowledge, does not cut down contrast sensitivity for distance. That being important for me, I'd probably stay away from compromised optic designed lenses, which is what multifocals and trifocals and bifocals are.
Thank you very much, sir. Thank you, Dr. Richard Davidson, for the excellent presentation, for having taken your valuable time off and spending it with us today. Thank you, Dr. Ramwale and Dr. Samresh, for your valuable.
Can
Yes,
I have
sir.
a minute at the end to have some 5 points to share at the end? Okay.
Yes, sir.
Can I do it now? Okay.
Please go ahead, sir.
Now, this is for all practices or ophthalmologists who wish to upgrade to multifocals. So let me give a 5-point guideline or the 5 steps which are important before you can start implanting the multifocal. First, the biometry has to be very accurate in your monofocal surgical practice. I would say not less than 90 to 95% of your patients should be seeing 6.6 or 6.9 without glasses. Second, choosing the patient is very important. There's enough data out there in the world on the internet and other ophthalmic forum that has to be perfected. Third, your surgical counseling skills have to be modified to the reality of multifocal, high pricing, because it also increases visual expectations. Fourth, it's very important that the surgical skills be such that your PCR rates be very low and your surgical time clearly less than 15 minutes. A person who takes more than that for a simple phaco cataract probably is going to cause a certain amount of tissue trauma, and it doesn't go. So a premium skill of a surgeon is required from a premium lens practice. And lastly, it's important that they under-promise and over-deliver. So these are the 5 guidelines for all practitioners who wish to upgrade to multifocals. Thank you.
Thank you so much for those valuable inputs, sir. And thank you for all the online viewers who keep encouraging us to come up with innovative topics. Thank you, Dr. Ashwin, and the clinical board for organizing this excellent lecture. Thank you once again, everybody.
Thank you very
all
much.
very
And thank
much.
you, Dr. Richard, and thank you, Dr. Prathiba, and thank you, Dr. Samaresh.
Thanks a
Have
lot.
a
My
good
pleasure. Pleasure to meet you all. Thank you so much. Have a good day.
My pleasure. You too, good day.
Thank you very
Bye-bye.
much.
Thank you.
Bye.
Good night.